Hello, I'm Dr. Amany Refaat, and I'm going to talk to you today about cancer health disparities. Our lesson will cover introduction, epidemiology, potential causes of cancer health disparities, cancer site-specific disparities, and conclusion. Introduction. Cancer health disparities are defined by the National Cancer Institute, NCI, as adverse differences in cancer incidence of the new cases, cancer prevalence, all existing cases, cancer deaths, mortality, cancer survivorship, and the burden of cancer or related health conditions that exist among specific population among the US. Healthy disparity population, especially racial ethnic minorities, also have lower life expectancy, higher mortality and morbidity compared to whites. In addition to overall health, individuals from these groups experience lower quality of care and have more problems accessing health care. In some cases, these differences appear regardless of income or coverage by health insurance. Causes of health disparities are varied and complex, but include factors such as physical environment, where we work, live, and play, social environment, interaction with family, community, schools, and places of worship, behavior, health choices, diet, exercise, smoking, alcohol use, and biology, genetic profile. The complex nature of health disparities necessitates multi-level, comprehensive plans and programs that involve multiple disciplines to address the after-mentioned etiological factors. Epidemiology. Although cancer determinantal effects are felt across all demographical groups, some groups are more affected than others regarding incidence, survival, and mortality rates. Overall, cancer mortality rates for all cancers sites combined have already decreased or remained stable since the 1990s. Blacks or African Americans have the highest incidence and mortality rates for all cancers, all sites combined compared to any other racial or ethnic group. As you can see here, different groups from ethnicity and how these different in cancers, which are more in some ethnic groups. White non-Hispanic women have the highest incidence rate of breast cancer, of about 128 per 100,000 women, and have for the last 2 decades. However, Black women breast cancer mortality rates, about 30 per 100,000, are astonishingly higher than women of all other races and ethnicities. Overall, colorectal cancer incidence in the US has decreased over the last 30 years. However, in the last 10 years, the incidence rate has slightly increased among individuals younger than 50 years of age. Blacks have the highest colorectal cancer incidence, about 49 per 100,000 individual, and mortality about 20 per 100,000 individual rate compared to any other race or ethnicity. The disproportion impact of prostate cancer among Black men in the US has persisted over the past 2 decades. Prostate cancer incidence rates are nearly 70% higher in Black men compared to white men. In comparison to whites, prostate cancer afflicts Black men at an earlier age, higher grades, and more advanced stages. Due to late-stage presentation at time of clinical diagnosis, the rate of cure and survival are low for blacks as compared to whites. However, strides are being made as it relates to this disparity. From 2003 to 2012, the incidence and mortality of prostate cancer decreased significantly among black men. For both men and women, lung cancer is the second most commonly diagnosed cancer and is the leading cause of cancer-related mortality in the US. An examination of lung cancer rates shows that it affects some races more than others. There has been a decrease in overall lung cancer death rates for blacks and other racial and ethnic groups. However, the disparity continues to persist. Blacks suffer from lung cancer more than any other population among the US. Blacks have higher mortality and incidence rates as compared to whites and lower survival rates. Black men are 18% more likely to develop lung cancer compared to white men. Blacks tend to present the lung cancer at a later stage and were less likely to receive appropriate therapy and timely cure compared to their white counterparts. This partially contributes to lower survival rates. About 13,000 women will be newly diagnosed with cervical cancer in the US in 2017. From 2010 to 2014, the cervical cancer age-adjusted incidence rate for all races was 7.4 per 100,000 women, and the mortality rate was 2.3 per 100,000 women. Hispanic women have the highest incidence at 9.1 per 100,000 women, followed by black women. Black women have the highest mortality at 3.8 per 100,000 women, and Hispanic women have the second highest mortality. More than 60% of cervical cancer cases occur among underserved and underscreened population of women. Potential causes of cancer health disparities. Social determinants. Cancer health disparities are a very complex set of issues that include a myriad of potential causes. One significant contributor is social determinants and their impact on health disparities. According to the WHO, World Health Organization, social determinants of health are complex, integrated, and overlapping social structure and economic systems that include the social environment, physical environment, and health services, structure, and societal factors that are responsible for most health inequalities. Social determinants of health are shaped by the distribution of money, power, and resources at the global, national, and local levels, which are themselves influenced by policy choices. More specifically, social determinants include areas such as discrimination, child development, social support, transportation, working conditions, housing, food security, healthcare services, culture, and socioeconomic status. Socioeconomic status, SES, is the term that is used to describe one's place in society related to education, income, employment, and insurance status. All of these factors potentially affect the risk of developing and surviving cancer. It is well documented that blacks scores lower on measures of SES compared to the white population. About 14% of the US population lives in poverty, representing 9% white and 24% of black. Socioeconomic status plays a major role in access to health care, health services, and health insurance. There are studies that have shown that health disparities track more closely with socioeconomic status than race or ethnicity. Low socioeconomic status, lack of health care access, and lack of health insurance tend to be fairly prominent causes of health disparities. These individuals are also often diagnosed at later stage of disease. Many of these cancers can be prevented or treated effectively if diagnosed. Disparities in access to care and insurance coverage. Access to care is critical in addressing an individual's health needs. Having access means that the patient has a doctor or healthcare provider, hospital, or clinic that is available. That means to get there, and the financial ability to pay for the cost of the visits and the treatment, if necessary. When all minority communities are compared to whites, they are less likely to have health insurance, have more difficulty in getting care, and have fewer choices in which to receive needed care. Significant data support that the lack of healthcare insurance significantly contribute to healthcare disparities. Lack of insurance often impacts when and where individuals get treated for a medical condition. Furthermore, minorities are much more likely than white to be uninsured or underinsured. Underserved and low-income communities are placed at disadvantage in receiving necessary screening because those with health insurance are more likely to have usual source of care than those who are uninsured, and underserved communities are considerably less likely to have health insurance. For example, lacking access to care because one is uninsured greatly affects participating in cancer screening. Not being routinely screened increases the chances of presenting with cancer at later stage when it is harder to treat, increasing the disparities in cancer mortality. Behavioral risk factors. Many forms of cancer can be attributed in part to behavioral risk factors such as smoking and tobacco use, diet, exercise, and obesity. Socioeconomic status plays a role in behavioral aspects of cancer risk. Those who are at lower socioeconomic status tend to engage in riskier health behavior such as smoking and tobacco use, lack of exercise, increased alcohol use, and lower uptake of screening recommendation for most cancers. Obesity, exercise, and diet are well-known risk factors for cancer. According to data collected by National Health and Nutrition Examination Surveys, Black and Hispanic men and women have higher rate of obesity compared to non-Hispanic whites. Further, an examination of exercise levels revealed that white men and women report the higher levels of exercise compared to all other minority groups. Most of these behavioral differences can be attributed to being poorer and living in minority communities. Within these communities, there are fewer resources, inadequate housing, fewer safe recreational facilities, less access to grocery stores that sell fresh fruits and vegetables, greater exposure to carcinogens, and marketing strategies that target this community for tobacco products. It is also believed that culture, health literacy, attitude, and beliefs also play a role in health behaviors within minority communities. Cancer site-specific disparities. Breast cancer disparities. Breast cancer mortality continue to decrease. However, racial and ethnic disparities persist. Black women breast cancer mortality rates are higher than other women of all other races and ethnicities, and Black women are diagnosed at an earlier age. White non-Hispanic women have the highest incidence rate of breast cancer and have for approximately the last 2 decades, while Asian Pacific Islander women have the lowest incidence of breast cancer. Black women 5-year survival rates are also lower, 80% compared to white, 80% compared to 91%, in part due to diagnosis at more advanced stage. Hispanic women are also diagnosed at more advanced stage, partially contributing to a poorer prognosis. Native Hawaiians and Native Americans also have a worse prognosis than white women, while Japanese Americans women breast cancer outcomes are better than those of white. The existence of breast cancer health disparities has been documented over 30 years. However, the causes of disparities in breast cancer prognosis, incidence, mortality, and survival rates are not yet conclusively understood. Social determinants such as culture, socioeconomic status, and social justice have been commonly cited as major contribution to observed differences in breast cancer detection, treatment, and outcomes. Within the broad category of culture are more nuanced contributors such as folk beliefs and intrinsic mistrust of the healthcare system and perceived invulnerability. The role of socioeconomics, particularly poverty, is demonstrated via less access to quality healthcare, absence of a prime care physician, and inadequate or no health insurance. Health insurance often influences a woman's decision regarding when, where, and what type of care to seek, perhaps resulting in the delay of care due to the cost of testing and treatment. The delay can exert a detrimental effect on timely diagnosis and treatment. Unfortunately, in many cases, Black and Hispanic women delay follow-up and treatment longer than white women, especially after abnormal mammograms. However, when Black women do seek treatment, disparities in the prescribed treatment have been noted also. Biological factors such as family, history, genetics assume a vital role in onset of breast cancer, and in its impact continues to be avidly investigated, with one study suggesting that there is a critical interplay between biological and non-biological factors that impact breast cancer presentation and outcome. As such, genome-wide association studies are being undertaken, and genetic testing continues to gain prominence as women desire to make more informed decisions based on their family history. However, marked disparities are apparent regarding genetic counseling participation, with significantly fewer Black women understanding genetic counseling or receiving genetic counseling compared to white women with similar family history of breast or ovarian cancer. The disparities that are observed with breast cancer are also due in part to behavioral factors such as nutrition, physical activity, breastfeeding, and screening behavior. Numerous studies have highlighted and the association between physical activities and cancer, namely overweight individuals and those who do not engage in the recommended amount of physical activity are at higher risk of cancer. Indeed, physical activities have been associated with a 64% decrease in breast cancer risk among Black women. However, in a study of sisters of women with breast cancer, results indicated that Black women consumed fewer fruits and vegetables and were less likely to meet the recommended body mass index and amount of physical activity compared to white men. Moreover, as a group, these women were no more likely to engage in healthy eating and physical activity behavior than the general population, despite being at a higher risk for breast cancer due to their family history. Even Black female breast cancer survivors engage in less physical activity compared to female survivors of other races and ethnicities. Obesity has also been shown to exert an adverse effect on breast cancer risk and survival among women with Asian ancestry. Strategies to reduce and eliminate breast cancer disparities in research, practice, and policy and communications have developed to address contributors to breast cancer disparities. There are varieties of approaches designed to predict the risk for breast cancer, as well as to better understand environmental and behavioral factors. The Gale and contraceptive and reproductive experience care models are two of more commonly accepted breast cancer risk assessment models. As with many models, these two were initially developed for white women. The Gale model was not validated among Black women and consequently underestimated risk among this population. Therefore, the CARE model was developed with an aim to supplement the Gale model. Media campaign and grassroots initiatives have also been launched to combat breast cancer and show support for those affected. Most notably, the National Cancer Institute Cancer Moonshoot represents an unprecedented investment in improving cancer treatment and ultimately discovering a cure. The 1.8 billion commitment is allocated to fund innovative research and practice across symbolic content areas. A convergence of these areas is designed to produce comprehensive, effective solutions to cancer prevention and treatment. Campaigns such as Stand Up to Breast Cancer have increased national interest and action. The month of October has been widely embraced as Breast Cancer Awareness Month. Cervical cancer disparities. Prior to the 1950s, cervical cancer was one of the major causes of cancer deaths in women. Since then, there has been a decrease in cervical cancer incidence and mortality rates, which can be attributed to advancement in the early detection of cervical cancer via the papinocular pap smear test. For women on whom precancerous lesions have been detected through pap test, the likelihood of survival is nearly 100% with appropriate evaluation, treatment, and follow-up care. The human papillomavirus, HPV, causes almost all cervical cancer cases. Specifically, two strands of HPV, HPV-16 and HPV-18, cause about 2/3 of all cervical cancer cases. The Federal Drug Administration, FDA, has approved 2 vaccines for girls and boys aged 9 to 26 years to prevent HPV infection caused by these 2 strands. Even with the advancement in cervical cancer screening and prevention, there remain groups of the population that suffer disproportionately from cervical cancer. Minority women, women living in certain geographical regions of the US, and low-income women are more prone to be diagnosed with and or die from cervical cancer. To address these disparities in cervical cancer, researchers and health professionals are strategically working to promote prevention through HPV vaccination and early detection through pap smear testing. Epidemiology of cervical cancer disparities. Hispanics have the highest incidence rate of cervical cancer. Black women have the second highest incidence rate and the highest mortality rate. Higher cervical cancer rates are associated with low income, lower education level, and medically underserved population. Differences in cervical cancer screening rates also exist among certain population groups. Asian and Hispanic women are less likely to report being up to date on pap smear test screening. Additionally, women with higher education and access to healthcare are more likely to have had a pap test within the last 3 years compared to those with a high school degree or less and uninsured women. Cervical cancer causes of disparities. Even though cervical cancer is nearly a preventable disease, there are underlying environmental, social, behavioral, as well cultural issues causing disparities among proportion of US population. Cervical cancer screening, incidence, and mortality rates are widely varying according to socio-demographic factors and access to healthcare services. Major factors contributing to cervical cancer disparities consist of lack of access to care and experiencing cultural barriers that lead to screening non-adherence, low knowledge levels of HPV infection, vaccination, and cervical cancer risk, and inappropriate follow-up for abdominal pap smear. Socioeconomic barriers affect access and affordability of care and of screening service. That factors that usually measure socioeconomic status, income, poverty level, and education level have all strongly been associated with higher cervical cancer incidence and mortality rates. Socioeconomic status is a strong predictor of cervical cancer screening, diagnosis, and treatment outcomes. Women living below the poverty line are 3 times more likely to be infected with the high-risk strain of HPV than those who are not poor. Lacking access to healthcare services is strongly correlated to low cervical cancer screening rates and receiving appropriate treatment. A usual source of care and a physician's recommendation have been shown to be strong predictors of pap testing in many populations. Cervical cancer screening rates are about 1/3 higher in insured women, it's about 84%, compared to uninsured women, which is 61%. Cultural barriers affecting screening participation also exist. For example, Hispanic and Asian women's non-adherence to cervical cancer screening is associated with low acculturation, limited English proficiency, and being born outside the US. Other cultural barriers include stigmas of sexually transmitted disease and fears of fatalistic beliefs about cancers. Strategies to reduce and eliminate cervical cancer disparities. Key strategies for reducing and eliminating cervical cancer disparities should focus on increasing access to care and improving information and communication. In particular, community-based education and outreach efforts are crucial for promoting prevention, early detection, and increasing knowledge and awareness of cervical cancer. Community health workers, CHWs, are also promoters, patient navigator, or lay health advisor, have successfully provided cancer education, helped minority women navigate screening services, and drastically increasing participation in pap testing. In the Appalachian region, patient navigators have been utilized to increase access to abnormal pap smear follow-up care among underprivileged women. Strategies to address disparities in the Asian community have sought to educate and inform women on the importance of cervical cancer screening, explore the relationship between cultural factors and screening behavior, and connect women to low-cost providers or providers who do not require health insurance in local community. Several facilitator barriers to receiving the vaccine were identified, which highlights the importance of culturally tailored education to address gaps in knowledge of HPV and cervical cancer. Another vital strategy in reducing cervical cancer disparity is the CDC National Breast and Cervical Cancer Early Detection Program, which seeks to increase access to screening services for women. two federal laws, Breast and Cervical Cancer Mortality Prevention Act at 1990 and Breast and Cervical Cancer Prevention and Treatment Act of 2000 have led to the creation and funding of NBCC EDP. NBCC EDP provides low-income, uninsured, and underserved women access to timely cervical cancer screening and diagnostic services. From 2011 to 2015, NBCC EDP screened nearly 900,000 women for cervical cancer. 41% of them are white, 32% Hispanic, 14% Black, 7% Asian Pacific Islander, and 5% American Indian Alaskan Native. Colorectal cancer disparities. Colorectal cancer is one of the few cancers that is considered largely preventable due to effective screening and removal of polyps. Early-stage colorectal cancer may not present any symptoms, thus screening is the key. A colonoscopy every 10 years is the preferred screening strategy as it has the potential to image both cancer and polyps, thus increasing the chances of removing any polyps and preventing cancer. Colorectal cancer risk can be decreased by increasing intake of milk, calcium, and high blood levels of vitamin D. Also, non-steroidal anti-inflammatory drugs such as aspirin, menopausal hormone therapy among high-risk population have been found to lower one's risk of colorectal cancer. Colorectal screening is the lowest among underserved populations, including minorities and the poor, resulting in high mortality. A possible rationale of the low screening rate is that colorectal screening test depends on a clinician referral, unlike screening exams for breast or cervical cancer. Thus, many postulate that effective communication between providers and patients is needed. This is especially true in the case of discordant race relations between doctors and patients, when their differences in culture may impact their discussions and the ability to convey the meaning and significance of screening. Colorectal cancer is the third most common cancer diagnosis in all men and women, following prostate in men and breast in women. About 91% of colorectal cancers are diagnosed at age 50 or older. A recent trend shows colorectal cancer incidence decreasing in large part due to increased screening that detect and remove precancerous polyps. This is the epidemiology. Fortunately, incidence and mortality have declined in the past 20 years. However, many preventable cases of colorectal cancer still arise. Colorectal cancer is more frequent in blacks. Colorectal cancer is the second most common cause of cancer deaths. Overall, blacks are 38 to 43% more likely to die from colon cancer than white. Blacks tend to be diagnosed at a later stage, suffer from better differentiated tumor, and have worse prognosis when compared with white. Blacks are more likely to develop colorectal cancer overall at a younger age, be diagnosed at an advanced stage, and have higher colorectal cancer-related mortality. Causes of colorectal cancer disparities. Numerous patient, provider, and healthcare system barriers impede appropriate screening and early detection among minorities. For example, patients often lack awareness about screening recommendation, lack a regular doctor or doctor's recommendation for screening, and are burdened by the cost of copays or deductibles. Minority cancer patients often lack health insurance, need assistance with transportation, or cannot afford to take time off work. Some fear the screening test or test results and experience language or cultural barriers in the medical encounter. Additionally, providers often lack knowledge about current regulations or do not follow current best practices. Some providers lack office reminder system for screening and have an inability to meet the needs of a multicultural practices. Strategies to reduce and eliminate colorectal cancer disparities. A number of strategies have been enumerated as way to curb colorectal cancer disparities, including increasing access to services and patient-provider communication that involves informed decision-making about the appropriate screening, follow-up, and treatment. Providers' recommendation is essential to patients' adherence to colorectal cancer screening. Such discussion should include information about screening types, likelihood, adherence, and consideration of patient preference and availability of service. It is recommended to implement strategies for increased screening such as patient and provider reminder system, messaging via videos and brochures, eliminating time and distance barriers, and providing provider feedback on patient outcome. Screening for colorectal cancer is a largely underutilized preventive public health strategy. It is possible that continually low screening rates are due to part to the complexity of the screening recommendation. Prostate cancer disparities. When compared to men of other racial and ethnic groups, prostate cancer has affected Black men at an unmatched rate. Despite declines in prostate cancer incidence and mortality, Black men continue to have the highest incidence rate for prostate cancer in the US and are more than twice likely as white men to die of the disease, with the only well-established risk factors for prostates being age, race, and family history. There has been an increased focus on better understanding the genetic basis of the disease, interplay with the social and environmental context, and individual behavior. Epidemiology of prostate cancer disparities. Prostate cancer is the most commonly diagnosed cancer and the second leading cause of cancer-related deaths among US men. The disproportionate impact of prostate cancer among Black men in US have persisted over the past 2 decades. Black men experiencing a 70% higher incidence rate and are twice likely to die in comparison to white. From 2003 to 2012, the incidence of prostate cancer has decreased significantly by 3.4% yearly among Black men, and deaths from prostate cancer have decreased significantly by 3.6 yearly among black men. In comparison to white, prostate cancer afflicts black men at an earlier age, higher grade, and more advanced. As a result, late-stage presentation at the time of clinical diagnosis, the rate of cure and survival are low for black compared to whites. Causes of prostate cancer disparities. The non-modifiable risk factors for prostate cancer are being black, age, and family history. For men whose father, brother, or son has had prostate cancer, they have a higher than average risk of prostate cancer. Although screening and early detection as a secondary preventive strategy have contributed to the decline in prostate cancer mortality, the scientific evidence to date has not definitively shown that screening with the prostate-specific antigen PSA test reduces death. The uncertainty with the biomarker PSA has led to much contention between clinicians, researchers, advocates, and policymakers. The contention relates to part to the biology of the prostate cancer. Prostate cancer is biologically heterogeneous, where some prostate cancers grow slowly and never cause symptoms, while other prostate cancers are fast-growing and metastasize quickly. The PSA is currently used as the clinical standard to detect prostate cancer. Although socioeconomic factors such as access to healthcare play a major role in the observed disparities in outcome, recent data suggests that biological and genetic factors may also contribute to a more aggressive form of prostate cancer in black men at the time of initial diagnosis. Black men often present with higher PSA level, a higher pathological grade of disease, and a higher tumor burden. The variation in disease characteristics observed between black and white men suggests that race-specific factors play a role in prostate tumor biology. Strategies to reduce and eliminate prostate cancer disparities. These strategies include the use of decision aids for prostate cancer screening and treatment in clinical and non-clinical settings, the use of lay health advisors through the community-based participatory research model, changes in public policy addressing health literacy, and advancing models of health communication in community-based settings. While most of these after-mentioned strategies focuses on increasing education and awareness, the process allowed for the examination of other etiological factors related to prostate cancer disparities. The goal to increase the knowledge levels of patients to a level that allows them to make an informed decision was found to be a unique challenge. The disparity in knowledge about different aspects of prostate cancer illustrates the need to develop targeted and tailored information based on the socio-demographic and characteristics of minorities population, such as age, educational attainment, income level, employment, marital status, and theoretically tested constructs of knowledge. While tremendous progress has been made in the context of health promotion and education, there is an imperative to address those multi-level factors that impact individual behavior. This includes the built environment, healthcare system, and policy, comprehensively and systematically addressing these factors would allow for the reduction and elimination of prostate cancer disparities. Lung cancer disparities. Lung cancer is the leading cancer killer in the US and is considered a highly preventable disease. It is uncontrolled growth of abnormal cells in one or both the lungs. These growths cause tumors and eventually interfere with normal functioning of the lung. Cigarette smoking is by far the primary risk factor for lung cancer, with the risk increasing based on the number of cigarettes smoked and the years of smoking. The US Surgeon General estimates that cigarette smoking caused 80% of lung cancer deaths in women and 90% of lung cancer deaths in men. Individuals who are non-smokers who are exposed to cigarette smoke have 20 to 30% greater risk and chance of developing lung cancer. Secondary smoking. The survival rates for lung cancer tend to be much lower than those for other common cancers. For example, the 5-year survival rates for all patients with lung cancer is approximately 18% compared to 64% for colon cancer, 90% for breast cancer, and 99% for prostate cancer. Black men have higher lung cancer incidence and mortality, despite the fact that blacks have a later onset of smoking and smoke fewer cigarettes per day compared to whites. Causes of lung cancer disparities. The causal factors that have been investigated regarding lung cancer disparities can be categorized as tobacco use, prevention awareness, environmental exposure, and genetics. Smoking tobacco tends to be concentrated in populations that have limited resources and low income and are minorities as coping strategy that addresses issues around stress, violence, and unemployment. Smoking tobacco is a particularly concerning issue within the black communities. Research has demonstrated that blacks have higher serum nicotine levels per cigarette smoked, resulting in a higher intake of nicotine per cigarette smoked and slower nicotine clearance. Additionally, it has been suggested that a difference in the use of menthol cigarettes may be the difference that are noted between black and white smokers. The effect of menthol cigarettes are still not very well understood, but it is believed that these cigarettes provide higher level of nicotine, a byproduct of nicotine in the blood, and these rates may be linked to increased level of addiction. The black community is disproportionately affected by lung cancer compared to other communities where the prevalence rate of smoking in black men is estimated to be approximately 28%, and disparities in incidence and mortality are significant. Knowledge has emerged as potential causal factors. Specifically, there have strategies to reduce and eliminate lung cancer disparities. Much like the strategies for the other cancers, more emphasis on education and awareness of the risk factors associated with lung cancer is essential. There are many public and private organizations and agencies that have developed effective intervention to address this issue. Many of these interventions have focused on advocacy work that includes tobacco control efforts, healthy air legislations, increased funding for research, prevention, and treatment, and finally improving the treatment for local advanced lung cancer. The differences that are observed in lung cancer include incidence among racial and ethnic groups tend to be influenced by genetic susceptibility to lung cancer, environmental exposure, and smoking prevalence differences. Given that smoking is the most preventive risk factor, there must be a focus on comprehensive tobacco control. From a policy perspective, enhanced smoke-free laws may have an impact on smoking rates across populations. In conclusion, disparities in cancer have a critical impact on society. Inequalities in health are simply unfair, and the notion that individuals have to suffer due to reasons primarily beyond their control is unjust. Health disparities affect everyone, not just the ones experiencing the inequality, resulting in a spillover effect. Those who are disadvantaged may lack the resources to participate in the social and economic mainstream of the society, which in turn will affect the health of everyone in the community. Eliminating cancer disparities would, in essence, result in better survival rates, enhanced health-related equality of life, quality of life, decreased medical costs, and perhaps in some cases prevention of cancer altogether. Promoting routine cancer screening would result in early detection and therefore less intensive treatment for the patient, helping to reduce the overall cost of cancer. The term healthy community was considered as a community that is continually creating and improving those physical and social environments and expanding those community resources that enables people to mutually support each other in performing all the functions of life and in developing to their maximum potential. Your learning resource in your package, here are the links, and these are links to YouTube videos included here, and thank you.